Hi, I'm Steve Selig, founder of FitTest, and in this second video is a small series on postural orthostatic tachycardia syndrome for exercise professionals. The topic in this video is how exercise professionals can work with clients with POTS, and another case study is presented. So I put this slide up in the previous video, part one. So it just shows you there's a large constellation of symptoms related to POTS and related to other conditions in the neurohormonal and also autoimmune cluster of conditions. So really there's a lot of comorbidity and there are a lot of non-specific symptoms in this condition. It also takes 6 months to diagnose based on the diagnostic criteria of increases in heart rate in adults of more than 30 beats per minute on standing, and that must be of more than 6 months standing for those symptoms to be relevant to this condition. I also showed in the part one what happens on standing. First of all, the condition is most common in relatively young females in the age group 18 to 40 years. And in this case, on standing, both blood pressure and heart rate have gone up quite noticeably. The difficulty with POTS is that sometimes blood pressure has no change on standing and other times blood pressure falls. And we can even get situations where blood pressure falls to the extent of having pre-fainting symptoms, even in the setting of big increases in heart rate. So it's a relatively difficult condition to manage in terms of as an exercise professional, because although we expect heart rates to go up both at rest, on standing, and in exercise, on particularly upright exercise such as running, we expect that, and we expect very high heart rates well above age predicted heart rate peak. What we don't know is what is going to happen to blood pressure. So blood pressure can go up, it can go down, or it can stay the same. And this means that we need some more monitoring, because all of these, especially in the situation of falling blood pressure, we can get symptoms arising. So it is a fairly difficult syndrome to manage as an exercise professional. I would put it right up there with the conditions that I have the most challenging times in managing properly, but we can do it. And I'm going to show you my approach in this video. So just some advice for exercise professionals pre-exercise, because it's a hypovolemic problem generally. Now, most clients, you can give a recommendation for pre-hydrating and pre-feeding according to the conditions prevailing. That would be the weather and the intensity, the intended exercise intensities and volumes. We need to take pre-exercise vitals where we can, that is resting vitals, especially heart rate, but also blood pressure if you have that available and you're competent to measure blood pressure, and obviously intervene if necessary. In the setting of exercise, the intervention may be no more than recommending that the person doesn't exercise on that day. Now, you won't know that if you don't do your pre-exercise monitoring. Take a rain check on your client's recent signs or symptoms, or their signs and symptoms since the last session with you. If this is a new client, I strongly suggest you take a medical history or have one provided to you, especially comorbid conditions that may affect heart rate and blood pressure, and record any adverse signs or symptoms, especially those related to exercise. In other words, talk to your client. Try to anticipate adverse signs or symptoms that might arise from POTS or other conditions, especially those that are going to affect heart rate or blood pressure. Now, for exercise itself, monitor heart rate, obviously, which we can do in a multitude of very simple methods available to us these days. So there should be no excuse for not monitoring heart rate in these clients. Also, blood pressure, if it's available and feasible. And by feasible, I mean if someone's on a treadmill, then it's probably not feasible. But if someone is on a cycle ergometer where their hand is still, then it may well be feasible. Of course, if they're riding on a road bike, then it's not feasible. It is normal for heart rate during exercise to exceed and well exceed their age-predicted heart rate peak. Try to use a ramp up and down plan. So by ramping up, we're just bringing the exercise intensity slowly up to whatever level we want and ramp it down as well at the end. This may enable you to control both heart rate and blood pressure better than if you simply went to whatever that work rate was. Now, that is obviously not feasible often for competitive sport and competitions, but in the case of competition, try and use this model here of ramping up and down in the warm-ups and cool-down phases. And where you can, if someone is off the field and coming onto the field, try and do some ramping up before they go back on. Stop if adverse signs or symptoms arise. And for post-exercise, I truly believe that you need at least 10 minutes of monitoring. And that monitoring might be self-monitoring, but you need monitoring. Try and take post-exercise resting vitals as you did in the resting phase, especially heart rate and blood pressure if they're available. And recovery interventions, be ready if someone is going to faint that you may need to lie them down and get their feet elevated. Just be ready for whatever you think you're going to need to do. So now coming to my case study of a 35-year-old female with POTS and orthostatic hypotension. In 2019, early 2019, she was admitted to hospital for 14 days. Take note of that, with repeated episodes of orthostatic hypotension and multiple faints and POTS. She was controlled before discharge with a beta blocker metoprolol and the alpha agonist midodrine, which I'll talk about. So the metoprolol will have a big effect on dropping heart rate, effectively dealing with the POTS, but it will put down blood pressure. So the midodrine was given in conjunction with the metoprolol to deal with the orthostatic hypotension. And it's a fast-acting, short-acting, hypertensive promoting drug to lift blood pressure when blood pressure is falling. So those medications I've just mentioned, and the midodrine, because it's a fast onset, short-acting alpha agonist, short-acting vasoconstrictor to put up blood pressure when she's going to faint, that was programmed to be given at 8 in the morning, 12 and 4 p.m. Exercise. She had mild post-exercise symptoms of lightheadedness and some blurred vision. Supine lying with the feet elevated quickly alleviated her symptoms. When she got up into a sitting position at about 2 minutes of recovery, her symptoms returned, and so she resumed supine lying. We gradually got her up to sitting and then standing and then walking with no significant falls in blood pressure or heart rate. This took about 15 minutes and then she left the facility. By no significant falls, I mean an overshoot in heart rate. Obviously, she's got POTS with the big heart rates, but this was to prevent an overshoot in heart rate. So the exercise recommendations were, as I talked about before, to do a ramped warm-up, continuous exercise at the intensity intended, moderate intensity, and then a ramp down for recovery. But also we could do a very similar model using moderate intensity interval training or MIT. Same thing, active lower intensity recovery intervals to try and keep blood pressure up in the right range, followed by a ramped active recovery back to rest. So that was the model, and that worked pretty well. So thank you for watching this video, and you can get back to me at info@myfittest.com.au. Bye for now and have a great day.